Hello, everyone. Nice to meet you again. Today, we will answer the critical questions related to fertility preservation in patients with breast cancer. First question is fertility preservation really important for patients with breast cancer? Don't they really need to survive only, and that's enough for them? Do they think of having babies after they're treated with breast cancer? Well, many studies have tried to answer that question. Mainly survey-based studies where they ask patients with breast cancer about their preferences and their needs. So this is a study that included more than 600 patients with breast cancer with a median age of 33. And here, the majority of patients, 57%, were seriously concerned about being sterile. This concern was very significant to them that they needed to discuss with the physician. However, 51% of them uh, really reported that their concerns were adequately discussed, while the rest they were not satisfied with the discussion. Moreover, around one third of the patients said that their concerns could interfere with their treatment decision and their compliance to treatment later on. This is a very important point. So it's not only about having babies, but also about compliance to radical treatment. Another very important study that included more than 200 patients with breast cancer and with a median age of 47 years, recalling their concerns about fertility. Well, 73% of them had already children previously before having breast cancer. However, around half of the patients desired having children again after being treated with breast cancer. So the second question takes us one step back. Does having breast cancer really affects fertility, and how does it cause infertility? Many studies have addressed this point. This is one of them, a Scottish retrospective huge study of more than 23,000 women with cancer before the age of 40 years. And the study compared the cancer survivors to the expected pregnancy rate. And cancer survivors had 38% less pregnancies than expected. In addition, specifically in breast cancer patients, they had 64% less pregnancies than expected and ranked the second among all cancers. So the rest of the question remains very important. How does cancer affect fertility? There are three main reasons that we can trace to the infertility related to cancer. First, the age. Second, the cancer treatments itself used to treat cancer. And third, the doctor's attitude. Well, everyone knows that age really modulates fertility. But how big is the problem? Now, in front of you, you can see the number of growing follicles curve against time. And as expected, with time, the amount of follicles inside the ovary, that's the ovarian reserve for future pregnancy, declines with time. The problem in cancer that in cancer comes with age. So cancer is usually diagnosed after the age of 35 to the age of 50 when talking about the childbearing age related cancer. And that's much more common than having cancer before the age of 35. And in addition, the cancer treatment itself takes valuable time out of those years. So, for example, in breast cancer, you take between 6 months to 5 years minimum to treat cancer. The second problem is the drugs we use to treat cancer. It's very well known that chemotherapy has a gonadotoxic effect. But if we dissect the chemotherapy protocols we use to treat breast cancer, we can see the difference. First, the oldest chemotherapy combination chemotherapy protocol that we use is the CMF or CMF-like regimens. CMF causes infertility in patients who are less than 40 years, around the percentage of 50%. But in those with more than 40 years of age when starting chemotherapy, you approach 90% infertility rate. Again, with the shorter regimen of the AC times 4, which is relatively less gonadotoxic than CMF, you find it ranges between 1 in every 4 for those who are less than 40 years and 1 in every 2 for those who are more than 40 years. Again, significant risk of infertility. But what about the chemotherapy regimens that we use nowadays? And those are the 6 to 8 cycles of anthracycline taxanes regimen. You can find that again, 1 in every 3 for those who are less than 40 years of age, and 1 in every 2 for those patients who has cancer and are treated with cancer while they are more than 40 years of age. And finally, the cause that is striking to most of us that physicians' attitude and knowledge really affects having babies after treated with breast cancer. This is a study, a survey study that we did among oncologists from the different countries in the Arab world to know what's their awareness, what's their common practice, and the available tools that they have regarding fertility preservation in female patients with cancer. And to our surprise, we had found that more than 50% of all physicians lacked the service of fertility clinic in their cancer center or then in their clinic, and the rest they had either a remote clinic, fertility clinic in another center or even in another city. In addition, most of the physicians did not have access to the commonly effective fertility preservation tools. For example, the majority of physicians had access only to LHRH agonists during chemotherapy rather than ovum freezing, embryo freezing, or ovarian tissue preservation. While the LHRH agonist injections during chemotherapy could effectively preserve the ovarian hormonal function, but the value of this technique in preserving the fertility and the ability to get pregnant is really questionable. The third question that we need to answer is, does fertility preservation technology really succeed in patients with breast cancer? So, can we really increase the number of pregnancies and live births if we use this fertility preservation techniques? And the answer came from a very interesting paper published in JAMA Oncology in 2020 that it almost tripled the number of expected pregnancies if you use the fertility preservation techniques compared to if you do not undergo any of these fertility preservation techniques. So they do really work. You only have to offer them. The ESMO clinical practice guidelines have suggested a very good algorithm to help us to decide. First, if you have a female patient who has cancer and plan for a gonadotoxic therapy and she desires future fertility, then you should decide if she can wait safely for more than 2 weeks or if she cannot wait for 2 weeks. And for most patients with breast cancer, we can safely wait for more than 2 weeks where we have time to go for ovarian ovum preservation and freezing after ovarian induction. It takes a few days up to 2 weeks. Or you can go to the in vitro fertilization of this retrieved ovum and you freeze the embryo. This have higher success rate regarding pregnancy later on. Or if you have less than 2 weeks available, you could only do ovarian tissue preservation that can be done with laparoscopic. Again, the technique is relatively recent and it's not accessible to most centers. And there are much fewer babies that were delivered using that technique compared to the old available techniques like oocyte retrieval and embryo freezing. Finally, for all patients with breast cancer who will receive chemotherapy, they should receive also concomitantly LHRH agonist where you stop the ovulation. This can help preserve the ovarian hormonal function. It can help decrease the menorrhagia during chemotherapy. And finally, it might help in preserving fertility, at least in part. So quickly, how do we get the ovums? We do ovarian stimulations. That's typically by GnRH antagonist that starts second or third day of the menstruation. It can start in other days. That's called random stimulation protocol. And you do give the daily doses, and you monitor the ovulatory status using ultrasound and serum hormonal monitoring. And again, after you see by ultrasound that the ovulation occurs, you just retrieve the ovary, and either you do fertilization or you freeze the ovary. Another technique, which is a little bit modified from that ovarian stimulation, is called controlled ovarian stimulation. By adding the letrozole, the aromatase inhibitor, to the LHRH antagonist, you can decrease the peak serum estradiol levels. And in patients, especially in patients with ER positive breast cancer, we are really concerned about the high levels of estrogen that increases during ovulation, during induction of ovulation. So the fourth question of, does this technique using letrozole, that's controlled ovarian stimulation, does it decrease the efficacy of ovum retrieval, and is it safe during treatment of or induction of ovulation in breast cancer patients? Well, the short answer about effectiveness is yes. From that meta-analysis, it showed that uh, adding letrozole or controlled ovarian stimulation, it retrieves almost the same number of follicles as the regular techniques. And in addition, it also causes lower levels of estradiol level. That is very important when treating ER-positive breast cancer patients. So the fifth and the most serious question actually is it safe to go for those assisted reproduction techniques with those, whether it's controlled with less amount of estrogen or with a higher amount of estrogen? Is it safe? And if it's safe in ER positive patients where we really, the mainstay of treatment is the anti-estrogen. Well, again, in that Swedish study, it was patients with breast cancer who did controlled ovarian stimulation versus those who did not were compared regarding the survival following breast cancer. And you can see that there is no differences between the two arms, whether they did the assisted reproduction or they did not. And this is an evidence that you can go safely for induction of ovulation and assisted reproduction without risking the survival of patients from breast cancer. And this is a very famous meta-analysis that have conducted by Dr. Lambertini and colleagues, and it did show that not only pregnancy is safe, but numerically, patients who had pregnancy during following breast cancer looks like they have less relapses and less mortalities. We don't know the reason for that. It might be just confounded by that they are mostly survivors, but again, at least having pregnancy following breast cancer is safe and does not increase the risk of relapse. Well, you can ask me that pregnancy increases the levels of hormones, and in estrogen positive breast cancer, we tend to decrease the levels of hormones. So it is sure that this will be detrimental in ER positive patients. However, this study again compared the outcomes following pregnancy in patients who had breast cancer and were ER positive. And as you can see, totally identical disease free survival. So pregnancy does not increase the risk of relapse in patients who are ER positive breast cancer and are surviving after breast cancer. And finally, the most daring question of all. If a patient has an ER positive breast cancer and is under adjuvant endocrine therapy, that takes 5 years. And again, as we said in the beginning, it's valuable time. So patients might be in the late 30s, in the early 40s, and she needs to get pregnant as early as possible before the fertility starts to decline. So can we stop endocrine therapy for a while, get pregnant, and then resume back the endocrine therapy? Again, that is considered a very daring question. To stop endocrine therapy that is known to improve the survival for patients with ER positive breast cancer only for the reason to get pregnant. This very interesting study conducted to answer that exact question. The positive trial recruited patients with breast cancer ER positive who were under adjuvant endocrine therapy and who have completed from 18 to 30 months of endocrine therapy, whatever it is, and they desire to go for pregnancy. Those patients were allowed to stop endocrine therapy and to have a washout period of 3 months, then to give them a window of up to 2 years to get pregnant and might be having a little bit of breastfeeding, then to resume back their endocrine therapy and to complete the planned duration, mostly 5 years, but again, they are allowed to go for more. So the question is that technique safe in those patients? And of course, this was not a randomized study, but in that trial, the investigators had a synthetic control arm prepared from another study, that's the SOFT and TEXT, that recruited patients who are ER positive and young breast cancer patients. So this control arm did have the event-free breast cancer event rate and was compared to the outcome of the positive study. Well, interestingly, the pregnancy outcomes, again, out of the more than 500 patients that were recruited, 74 patients could achieve a complete pregnancy, and more than 60% of patients, they could have a live birth. Again, regarding pregnancy outcome, this is very favorable outcome and comparable to other who did not have breast cancer. So the most important question is, does that affect the safety of breast cancer? Does that technique of interruption of endocrine therapy and getting pregnant increase the risk of relapse? Fortunately, it did not. The patients who didn't interrupt the treatment to get pregnant, they had equivalent breast cancer event rate around 9% in the positive study, comparable to the control arm. And by that, we can conclude that interrupting endocrine therapy for up to 2 years in patients who had completed around 2 years of adjuvant endocrine therapy and then resuming again the adjuvant endocrine therapy after delivery is a safe technique and should be discussed with ER positive patients who would like to get pregnant and who did not have time to wait to complete the whole 5 years of adjuvant endocrine therapy without decreasing their odds of getting babies. Thank you very much for your attention. For more lectures, please subscribe to the YouTube channel and follow me on LinkedIn. Thank you very much again, and goodbye.